beautiful thing on the internet. When I think of it, babe, you'll be a 10 out of 10 if you never smoke cigarette. But can I blow
All right, guys. Welcome to each and every one of you. Let me close the decks down. Give me 1 second. All right, wicked. So welcome to each and every one of you to another Monday Night Live. It is Monday 25th of May. Had to look because time is going by so quick. Hope each and every one of you are keeping safe, keeping healthy, and looking after yourselves, and also enjoying the sunshine with your loved ones as well. It's been a busy few weeks. We hope each and every one of you enjoyed Janos Mako last week. We had over 150 applications for the competition. So 150 of you sent in your drawings of your molars, and I got to say I was shocked because the standards were super high. Because so many of you guys sent it across, Janos is making his way through it to pick the winner for the competition, who will get a space, 2-day course in London, hands-on with Janos Mako. So this week he will do a live announcement on our Instagram feed, so look out for that as well. But tonight we've got two great mentors of ours, two great implant surgeons who are going to unravel the world of implant dentistry. Now, I know a lot of you guys on today's webinar, we've got a big variety. Some of you guys are doing implants in practice. Some of you guys are thinking of starting to do implants very early on your journey. For myself as well, I don't do any implants myself, same as Kash, because I've got the great Sumair Khan working in our practice, but it's something I would recommend for the future. It will become a norm. And I wish I started placing implants early in my career. So I think today's gonna be a fantastic webinar. The guys went through it a couple of times with us, and every time I hear these guys, always learning off them as well. So I'm gonna pass you to Kash, who's gonna introduce our two great speakers today.
Thank you, Jin. Good evening, everyone. Hope everyone is keeping safe and well. Eid Mubarak to everybody that was celebrating over the weekend. Joining us live tonight, we've got two fantastic speakers, two very close friends and mentors of ours, Dr. Sumair Khan and Dr. Kash Hafeez. Between them, they have amassed over 24 years of clinical experience in implant dentistry. They are internationally renowned lecturers and are heavily active in the Royal College of Surgeons and Health Education England. Sumair has been a very close personal mentor for myself and Jin over the last 12 years, keeping us on the straight and narrow. And he's an incredibly talented clinician and educator. He has amassed a huge number of postgraduate degrees, not only in implant dentistry, also restorative dentistry, amongst others. Kash was actually Sumair's very first implant mentee many, many years ago. Don't want to say your guys' age at the moment. And he has been teaching oral surgery and implant dentistry all over the world for over 15 years. So you are in good hands tonight, guys. Going to pass you over to Sum and Kash.
Hello, guys. Can you hear me well?
We can hear you. Mate.
Yeah. Okay, perfect. We're going to go through some basics of implant dentistry today. And for the guys who are actually doing implants, it will be a refresher for them as well. And the guys who want to embark on this journey, it will be a good eye opener for them as well. So, Sumair, you want to start?
Yeah, before you guys start, first,
good evening, everyone. Can everyone hear me okay?
Sumair, before you guys start, Eid Mubarak to both of you. How was fasting?
Yeah, it's been difficult, but it was worth it.
Yeah,
it's been a strange one this year because of the lockdown. Everything's strange this year because of the lockdown.
And I've got to say, Sumair, lockdown, your hair is looking quite slick.
I know. That was courtesy of my wife yesterday, so thank you to her. And also, with regards to many of my achievements, one of the hardest things I've ever done is keeping Jin and Kash on the straight and narrow. I'm going to share my screen now because I want to show you guys what we're going to be talking about tonight. So just make sure everyone can see that. No. Need slideshow.
Now, while Sumair is setting up, if anyone has any questions tonight, As we do with every Monday Night Live, do write them in the Q&A at the bottom. Myself, Kash, will go Kash and Sumair at the end. And your questions don't need to be very clinical. They could be on how to start the implant journey, what to look for, equipment, whatever you want to ask. These two guys are heavily involved in education and implant dentistry, and we'll have all the answers for tonight.
Okay, guys, so I want to get us started. It is now 10 past exactly, and I'm going to try and get us finished around 10 to 9 if I can. Like Junior said, any questions, please do write them down, and we'll have a Q&A session at the end. It's pretty much going to be me talking and asking Kash to come and explain stuff on the screen that he's better placed to explain.
You can tell when Sumair starts talking, it's difficult to stop him.
When I am going through my cases, I've just gone through three, I think, or 4 cases in this presentation, showing the different complexities that primary care practitioners should be able to handle as implant dentists. I did have a presentation about how you start doing implants in practice, in terms of getting the team ready, getting the practice ready, getting the kit and equipment, and some of that will come into this. But Jin and Kish wanted me to talk through the type of cases that you might start with and then go on to do as primary care practitioners who are building a portfolio of cases towards a qualification. So let's just start this presentation so I can tell you what I'll be covering today. So in terms of the essentials, what we are going to be talking about is the essential skills that you need to become an implant dentist or to start providing implant dentistry in your practice by yourself, in your surgery with the team around you that you've trained ideally. So in addition to being a prosthodontist, a periodontist, and an oral surgeon, you also need to be able to manage the team around you and manage your own training and development going forward. So you've got to remember, implant dentistry in the UK, at least, is not a specialty. It is a form of fixed prosthodontics that the oral surgeons think only they should be putting in, prosthodontists think only they should be putting in, and periodontists started it all off, so they think they are the only ones who should be doing implants. But in fact, it is general dentistry, which is why it lends itself so well to primary care practitioners like ourselves. And that's why you should all be looking to do that as you're developed further on in your restorative and prosthetic practice. In terms of the standards, the essential training and requirement, this is the FGDP UK training standards in implant dentistry. Okay, it covers, it's freely available, or you can Google that or go to that web page there, and it kind of sets out the whole curriculum of, in a vague way, of what you should and shouldn't be able to do, or what the skills you should have to be able to place implants in primary care and in secondary care, in fact. It's all been adopted by the ADI, the Association of Dental Implantology, and the GDC. And what it does say in there is that implants are used, as you can read there, for the replacement of teeth, and the implant dentists must be, okay, competent in carrying out the procedures that are listed in this. Okay, it also talks about the dentist must have undertaken a suitable postgraduate training, which has included mentored clinical placement or clinical supervision, basically, and of placement, implant surgical placement and restorations. These training standards have been adopted by the ADI, who also refer to them, as do the GDC. So it is the standard that you need to know and lists what you should be able to do in terms of your skill set to be able to place implants in the UK. Is there anything else you want to add to that, Kash?
I think, to me, every practitioner who takes teeth out should be a part of implant placement team or implant restorative team. Because to me, the implant planning does not start after taking the tooth out and then thinking what we're going to do with this vacant space. It starts when the tooth is in. So if you are taking teeth out, you should be knowing about this stuff, how you're going to restore it. What if you're going to have an implant in there? So you just need to start thinking whether the tooth is still there.
Okay, thank you. Let's move forward. So, Continual professional development. You can just do implant dentistry with your BDS. If you plan it in your PDP as part of your continued professional development, you can go on to include implant dentistry. But you cannot attend an evening lecture or a weekend course or a week course and have enough knowledge to be able to place implants. And you can't even the most advanced degrees. So I know people who've done an MSc in implant dentistry, and during that time they only got to place one implant. The most important part is the clinical supervision and the mentoring. That's where the true learning happens, when you are immersed in implant dentistry and it is going on around you, and you're seeing the different stages that happen all the time, repeatedly, and getting involved. You don't have to do a master's degree. You don't have to do an Implant Dent. The minimum that I would recommend is a postgraduate diploma, because a diploma means that you would have produced a portfolio of cases that would have been signed off by a mentor and assessed externally. And that pretty much is what the indemnity people will ask you for. They will want to see that you've been mentored or that you have a mentor in place before they will indemnify you to place implants in the UK anyway. All right. So let's start with perio. I've got a few slides and then I'll let Kash chat to you about oral surgery. So I've said you've got to be a periodontist, you've got to be an oral surgeon, you've got to be a prosthodontist to be able to place implants. Those are the skills, those are the fields or domains in which you need to upskill in order to be competent or develop competence in implant dentistry. And with regards to perio, Nikos Donas at the Eastman there, he produced this paper in 2012, which was a nice summary, and he answered lots of different questions about placing implants, implant dentistry in patients who've had perio disease. And essentially, the most important thing is that this perio disease is controlled. And so as an essential skill for you to be an implant dentist, you definitely need to be able to recognize, diagnose, and at least treat yourself or get treated perio, and then reassess it and be able to see that it's stable before you can think about placing implants in those patients. Okay, I don't think it's good enough or defensible for you to see a patient with perio disease, as a lot of people do, decide that all their teeth need to come out before they lose any more bone, and place 4 implants in their jaw and give them an all-on-4 smile, because there's no going back from that. Whereas with perio, you really want to try and save as much as you can. And Nikos has suggested that there is a 2-level risk assessment. You risk at assessing the patient and you risk assess the site, which I like very much. Okay. The patient level assessment is based on very much on what the new BSP or new perio guidelines are based on, where you classify and diagnose patient and classify them as well. And the patient profile is also slightly different. Okay, so they're looking profiling the patient. The site level assessment is to do with the stuff we look at in terms of the surgery itself and the soft tissue and the hard tissue available, and especially tissue biotypes and proximity to things like sinuses and nerves. So the suggested 2 risk level assessment by Nikos Donas in the 2012 paper is pretty much what we do informally. When we're doing a whole patient care assessment for an implant patient, we will be looking at all the factors, but it's based on those 2 levels very roughly. And he's suggesting that there is at least a prolonged observation period. I know in the NHS that usually is 2 to 3 months, but what we mean is about 3 to 6 months of stability of periodontal patients before we start placing implants in them, because it is a high risk factor for peri-implantitis and implant failure. And the one thing you don't want to be as a primary care implant dentist is someone with a high risk or high rate of failure. Okay, I think this is so we've said the diagnosis and treatment planning for perio is a key. Everyone should be familiar with how to do the classification and diagnosis of their perio patients, and make sure that perio is treated before you go anywhere near them.
I think that's one of the most important issues in modern implantology, because we know that if we have an infection in the oral cavity, then the long-term prognosis of the inserted implants is going to be much worse. So especially in patients that are susceptible for periodontal diseases, we have the need to implement the adequate oral hygiene, to perform periodontal therapy, to get rid of the periodontal pockets, but also to ensure healthy hard and soft tissue around the implants. Before placing the implants, that would be the best.
Okay, so that was a summary of a conference that was run a few years back as well. So I'm going to finish off with a case here, the kind of case that you need to look for to get started on. This is Miss HR. She is young, healthy. She's she's actually a solicitor, I think. And she came to me. She had this heavily broken down upright premolar. I don't have an X-ray on here, but essentially that thing is not restorable, or at least any restoration I put in there would not be predictable enough for her. So she's came to me and asked for a implant supported. She would refer it to me after discussing with her dentist, and she was all pretty much geared up to have an implant supported crown. In this case, this is a simple type of case because there's no perio. The patient is young, fit and healthy. And there's no medical issues as well. I've taken a ball bearing, two X-ray, periapical X-ray there. That ball bearing 5mm allows me to calibrate the measurements on the X-ray, so I can see how long the root is to the sinus and how wide the root is mesodistally. What I cannot see here is how wide the root is buccopalatally, and for that I will use calipers clinically. And when I've taken the tooth out, that's when I will do a measurement of a socket as well. If you don't put anything in the socket, you can pretty much go in there straight away. So I took the tooth out in March, and then I waited until August to just basically place an implant, simple implant within the socket. So if we're doing it within 3 to 6 months of the extraction, usually when you raise a flap, you can see straight down the healing socket, and that's exactly where you put your implant. It's pretty much a no-brainer. It's a slam dunk in there. It goes down very easily, and then that can be restored. You can make sure, you've got to make sure, I mean, in simple cases like that, you can make sure that it's axial loading so you don't have cement retained restorations, and you can restore the space quite nicely for her as well. And that was restored for her the following year. Okay, so that's the type of premolars are nice cases to start with, ones that have no disease and no bone loss around them, ideally. Okay, moving on to essential skills in oral surgery. I've drafted them into these 3 categories just because those are the slides that follow, and I'm going to ask Kash to talk about these areas because this is something that Kash teaches minor oral surgery throughout the year. He teaches 5-day courses at Londek, and this is how Kash used to work for me when I was a TPD in London for my deanery job. He would just come in and teach oral surgery, and does a lot of skills, pig's head type courses on this. So Kash, if you want to first talk to them about these are the type of skills that we're talking about in oral surgery: anesthesia, raising a flap, mobilizing roots and moving them, preparing implant sites we'll come on to, and placing implants. But in order of, if you think about the things in order of you're going to carry them out during the procedure, let's go through them one at a time. So local anesthetic, Kash.
Yeah, so as Sumair said, that the implant planning is not about seeing a vacant space in the mouth and start filling it with a screw you've got in your hand. It's much more than that. You have to have a look at the holistic approach for the patient. So you need to get it sorted, the restorative part sorted, the perio part sorted. Everything has to be dealt with before you place that screw in the patient's mouth. So that you need to look into that. And my question to yourself, if you start thinking in your head, is that why would you actually take the tooth out and lose bone and then start thinking about making bone? The answer is that you do not let the bone go away. So your planning of implant starts when you have got the tooth in the mouth still. So we all know that when the tooth is taken out, you're going to lose 50% of the bone volume within 1 year. And my question again to you is, why would you let that 50% go away? And make your life difficult. So create simpleness for yourself. So if you have got a tooth in there, your implant planning starts there. And there's a question as well in here, which one of you have asked that when is the appropriate time to start getting the implant training post FD. My answer to that is that when you think that you are able to handle the incision, the elevation of the flap, when you are able to actually handle any bleeding inside the mouth which happens during your surgery. So if you can think that all these problems you can deal with, then you can start your training towards implant dentistry. Before that, you need to know how to incise, you need to know how to elevate the flap, you need to know how to achieve hemostasis in your patient. You need to know what kind of medications your patient is on and what kind of management will that patient require. For example, if the patient has got a respiratory problem, how are you going to deal with a patient which got emphysema? How are you going to deal with a patient who's got uncontrolled diabetes? What are the contraindications for implant placement?
And Kash, what
Yeah,
do you think about flapless implant placement? I've put on the slide. Can you see the slides,
yeah,
Kash?
I can.
Yeah, so you can see there that I've strongly said that I don't recommend guided implant placement or flapless for the novice implant dentists. It's very important that they are able to feel for a bone on a motor by direct vision in order to, like you can see, this type of surgical extraction of wisdom teeth. This is a type, if you can do that, that's the level of oral surgery skill that you pretty much need to be able to place implants. So do you agree,
Yeah,
Kash?
that's right. I mean, all my training was I worked quite a lot in oral surgery department. I started working with Sumair ages ago. He actually hammered in my head that I need to think as a restorative dentist. And if you've got training in oral surgery, then it's very difficult if you start thinking as a restorative dentist. But you need to think about the restoration first. How are you what kind of restoration you're gonna give? And then you plan your implant, you place your implant according to that. How are you gonna actually use the elevators, luxators, to actually minimally damage the bone? So for example, if you've taken a molar out and you have damaged the buccal bone, then how you have to replace it then in order to place an implant. So isn't it better to actually elevate the tooth properly without doing much damage with minimally invasive tooth removal or minimally invasive surgery, and that will give you a nice bony envelope afterwards where you're going to place an implant. So,
I mean,
yeah,
you get socket preservation techniques taught to you as well, but a lot of the time it depends on what the patient wants and time-wise, because sometimes by introducing bone or any kind of substitute into the sockets, you actually delay the healing and prolong the time before you can put the implants in. What I wanted to cover was, Kash, to talk about was flap management, in particular how you raise flaps and how you suture them, the importance of soft tissue closure when it comes to especially grafted areas. Do you want to cover these skills that are covered here, Kash, in the slide?
Yeah. So there's a question as well from Martin. I think he said that in that case you've showed, why didn't you go for a straight away immediate implant placement?
Yeah, Martin, because the immediate implant engages the bone apical to the socket. And if you looked at that, it's an upper 5. So the floor of the sinus is very close to the apex. So if I'm going to try and engage the apical bone, I will be trying to engage bone in the sinus of the 5. I didn't take the CBCT scan because when I took the 2-dimensional PA with the ball bearing, I could see that the root apex was in the sinus anyway. Plus it was root treated and it had been broken like that for a few months. So there's no doubt that there were bugs in the mouth that were free flowing in and out of that root canal, even though it was nicely root treated. And so the apical area, you can't tell that there's definitely no infection there. There would have been bugs at the apex. So I prefer to remove it, wait for healing. The minimum I will wait is 6 to 8 weeks for soft tissue healing, so that I've got a cap over the socket. Then I will open it, place the implant, and close over its top as well. So this is a type of kit that we use that you need to have access to and be familiar with using as well. Surgical drill units with saline drips, that's a PhysioMed dispenser, and you need to be able to obviously harvest bone when needed to, and the kind of kit that you need to prepare sites for implants as well. These are a set of osteotomes. They're very useful in soft bone, what we call D4 bone. The bone is D1 to 4. D1 is the hardest, that's in your chin. D4 is the softest, that's up here in the maxilla towards the sinus. And in the sinus sometimes, under the sinus, rather than remove bone, where it's scarce as well, sometimes we prefer to use osteotomes to expand the site. Okay, so getting that tactile feedback for bone is very, very important. Other operative requirements for implant dentistry, some of the essentials is having a lab that knows how to articulate study models and has a articulator that is calibrated ideally to yours as well. Having access to CBCT scans or a scanner where you can get the patient, send your patient to and get scanned, and obviously understanding how to utilize the staff in an aseptic technique, so you have a dirty nurse and a clean nurse at all time with you in the surgery during the surgical placement anyway. Some cases coming up. So prosthodontics, I'm not a prosthodontist, but I do fix some removable prosthodontics. I've been doing it in practice for over 20 years, and in the last 10 years, it's primarily been implant-based. But the important thing with prosthodontics is understanding dental materials and the mechanics of materials, but also biomechanics. For implant dentistry, you have to understand how various materials react with bone and soft tissue, and in terms of the long-term stability of, especially of the soft tissues around implants, because of the demands on the aesthetic outcomes now as well. So getting osseointegration is no longer the gold. It is no longer the key. Osseointegration is pretty much a given. It's what it looks like afterwards, the integration and the aesthetics. So of the so pink aesthetics and white aesthetics and the predictability of that. That is what we are aiming for and striving for now, which is why there's such a move towards soft tissue grafting, and either at the time of implant placement or at the time of uncover, and as you move forward. And underpinning all of that, so the mechanics of materials and the biomechanics, how the materials react with the bone and soft tissues, is underpinning all of that is the occlusion. Because on implants, as we know, they don't have a periodontal ligament. Once they are locked into the bone, they're locked in. They don't, there's no give at all. You have to plan the occlusion care on them very carefully. They don't do well with non-axial loading, and they don't do well with overloading. And it has a detrimental effect on the materials mechanically within the restoration and on the biomechanics, how those, the soft tissues and hard tissues around the implant, the stability of them is affected by the occlusion as well, adversely if you're overloading or if you're off axial loading. So this lady is 82 years old. She was actually brought to me by her daughter because she had a failing bridge. And I mean, it was gone. The bridge had been there for over 15, 20 years, I think. And I had a time getting it out and removing all that, and we had prepared a denture for her to wear, which she absolutely hated. Okay, you can imagine if you've been wearing this and been, and she was quite well-to-do, she well kept, she had all her faculties about her. She wasn't going doolally or senile or anything. She definitely wanted something fixed again. She came back all the time with a denture asking me to replace it. But the important thing was I didn't want to rearrange her occlusion. At the age of 82, to give her a new occlusion in RCP and inclusive OED, that wasn't the key here. The key here was to stick to what she had. So before I took all that apart, I took study models and had a wax up made of what she already had. So it was easy to make an Essex type suck down splint. And those are the type of splints that we tend to use as guides. So these aren't digital guides. These aren't precision guides. It is just an eyeballing guide. So you can fit that on the other teeth, as you can see in the picture there, and it tells you where the long axial loading and gives you the idea of where to put the implants. Because you can imagine in a ridge like that, for me to place 3 implants for the posterior bridge, because that's in the soft bone, and 2 implants for the anterior bridge, so 5 implants, I need to know where I'm going to put them distancing wise, angle wise, and it's easier if you've got a nice plastic shield like this, which is based on the wax up. And then again, you can see I've raised 2 flaps here, one for the posterior, one for the anterior, and it's in order to help me get closure as well over the top of that. and there was no grafting in this case at all. But it was all done in one hit. I don't tend to work with sedation, and I don't. And if it's going to be more than even full arches, the last one me and Kash did, I think, in Keelan's practice, there's no sedation there either. So, but I have done work with sedation. It's fine having a sedationist in the room, and you have to have a good working relationship with them, ideally, and it's easy to develop because they're professional as well. So this lady's had her 5 implants back in, when was that? Implant placement in July 2015, so it's an old case. And then, so she came to see me in December. So usually it's 3 months minimum we wait for integration. But again here, because of her age and a soft bone, we're waiting a little bit longer. And I've uncovered the implants and then taken an impression to get this type of framework made. So again, having a lab technician that knows what they're doing, having a lab technician who knows what components you're going to need and is familiar with how to put these things together and what kind of how to present it to you as well, because often you need it with a jig so that you can locate it easily, because some of the fittings will be passive and some might be active here because the implants are hexed internally. So it's important to work with a clinician that knows what they're doing, a technician that knows what they're doing. Not all technicians are the same. Not all labs can produce this type of work in a predictable manner that will allow you to restore an 82-year-old lady, and that was all fitted in the following year in February for her. And she was very happy with that, absolutely delighted to have her teeth back. The last case I'm going to go through with you is a case that I found quite challenging. This was a young lady who was sent to me for a second opinion and it was 2 weeks after she had come off her bike. She was hit by an Uber driver. She was on a bike. She's a student cyclist. Her face went straight onto the windscreen, and she lost one tooth. It was avulsed completely. The upper left one, you can see there, and the right one was in half. This is a temporary dressing someone else had put on, and that's vital but fractured upper left tooth there. She's got a class 3, bit of a class 3 with retroclined lower incisors. You can see there's calculus there as well. But she's a young, fit, healthy student, and she was in a bit of a panic because she had been to see someone in Harley Street who had quoted her £28,000 to remove the remaining incisor and this lateral here, and to put 3 implants in with a big graft, and to replace that 10 years later as well. So she'd been quoted £28,000 because it was all going through the insurance. So that's how she presented that on the day one. I told her I wasn't sure what to do. I had the scan from the previous dentist. I wanted to have a look at it to see if I would take all the lateral and the incisor out as well. And I gave her a temporary bridge like this to walk away with and check to check the occlusion, because it's only just positive there. It is pretty much edge to edge based, and I wanted her to show me some photos on what she looked like before as well. So that was in September. The accident was in September 2017. I saw her in October after I had taken some impressions and got a denture made for her. And I saw her to take the remaining root out of the upper right one and to essentially graft the 2 sockets and build that wall up. The buccal plate and the buccal wall, you can see I'm building outside the envelope of a normal thing there. And the reason we do that, overbuild that, is because you're going to get some recession no matter what. The moment you raise a flap like this and take it off the bone, the outer layer of that bone has lost its blood supply. And the research shown, Roberetti does a lot of presentations on that, and the importance of overbuildings, because there's going to be some recession there anyway. And meanwhile, it's this lateral that was keeping me confused, because whilst I could see why the other dentist had wanted to take it out, there was a huge defect in it within the root of it on the x-ray, which I hope you'll be able to see. I did that in grafting in October 2017. I reviewed her in March 2000, so I closed up after grafting. It's important, again, with the flap to have non-tensile. You don't want this to be all white and pinched. You want it to be pushed up against each other, so it's going to heal nicely. And then you can see that was in October. Sorry, I got that. Grafting, yeah, it was in October 2017. So this is November, December, March. This is 5 months later, not quite 6 months later, 5 months later. And you can see it's almost healed up. And then, so what I did is, and she's wearing a temporary denture. She was okay with that for a little while. She knew she was going to wear it for at least a year. So then in March, I scanned her, and I've just done this today. I brought this up to the level where you can see this defect in the two. That's a lateral incisor there. The blue lines in the lateral incisor. That's the cross section of the incisor. So there's a defect, but there's no apical pathology here on that lateral. There's a defect again. So I decided I would leave that as a composite resin. I asked her if she wanted a veneer, if she wanted it to match the other two crowns I was planning to place for her. She said, look, let's just leave it, because if you're going to take it out and put an implant there, then leave it. So that's it, restored with the composite resin for now. And in May, in the next year, these are the 2 holes. We could go in and raise a flap again. The bone's quite solid there. Drill 2 holes, very soft bone in some parts, but very hard. And then these are what we call tissue level implants. So this is a new make that I decided that I was going to use for her because of the aesthetic demands on this case. This lady, remember, is below the age of 30, and it was a front teeth, very front teeth. And I had no idea how much bone would resorb and how much it wouldn't, because a lot of this is all grafted bone. You can just see that there as well. So these are 2 Prama implants by a company called Sweden and Martina. There are tissue level implants, and the reason I like that is because anywhere along that head, you can pretty much place the margins of your crown using a BOPT type concept. This was the uncover. These are what we call Prama in hidden abutments, so they go down over that gold head to push the emergence profile for your crowns. These are 2 open tray impression copings, and you can see there's the impression copings there, and would have taken an impression for her. That was done in August, so we uncovered it and took the impression in August, and these are the crowns that we got back from the lab. This is Aesthetica lab with Mario. It's brilliant work, but you can see we want it to be screw retained. It's all palatally placed, so it's screw retained, and these are soft tissues under time of fitting in September. So if you remember, her RTA was in September 2017, and I fitted this, and that's still the composite on that lateral there, because I don't know what's going on with the root, but there's no infection. And this is at time of fitting. This is a year later, in September 2018, she got her crowns. These are the x-rays at the time of placement in May, at the time of the impression in August, and then when I fitted them in September 2018. And this is a year later, in September 2019, that's just gone. And soft tissues and bone all looks quite nice, all looks very stable. The lateral incisor is still very good, no kind of problems at all. Okay, so those are the cases. How do you get your practice prepared? How do you get yourself prepared to do this? What do you need to prepare for? So you need to prepare to be mentored. You need to have people in the practice that will work with you, or invite someone into the practice to work with you. You need people in the surgery who can take photos, people who can drape the surgery, people who understand aseptic technique and working in a clean environment, okay? All the members of the team have got a part to play, okay? So they will all need something added to their PDPs in terms of their personal development and training to do with your implant side of the business, or to do with implant training. Because implant dentistry isn't routine for dental nurses as well. Ordering CBCT scans isn't routine. Look, if you look at all the different componentry that comes with with restoring implants, it's like a minefield for dental nurses who aren't familiar with it. So that's why there are courses designed for dental nurses to teach them how to be implant nurses as well. Okay, because these kits are not simple. Kash, you want to talk about what we're looking at there?
Yeah, you need to see what equipment and all the armamentarium you've got. You need to have all the proper armamentarium for your implant placement, implant impressions, and fitting of the restoration as well. So there are no shortcuts in here. So you need to have all the things which should be there, because implant surgery, you are elevating the flap, and if you've got a bleeder, you need a hemostat to actually stop the bleeding. You need the armamentarium to stop that, to achieve that hemostasis and stop that bleeding. I want to add here about the idea of immediate placement as well. It's a very good attractor to the patients and to the dentist as well, because it's single stage surgery, and patient does not have to come back. The tooth is taken out, the implant goes in straight away. The patient walks out with the tooth in the mouth. But you need to think about there are quite a lot of things you need to actually have quite a lot of tick boxes in order to achieve that immediate implant placement. So start thinking about those things you need to have. You need to have that proper bony envelope for the implant to go in. You need to have decent amount of labial plate or buccal plate where you're going to place the implant straight away. And the biggest advantage
boxes, Kash, in terms of the tick boxes, yes, you need to have the buccal plate and things like that. I would go far as to say that, I mean, I got into immediate implants very late because I was taught the old dinosaur way. You wait, take a tooth out, you wait 6 months, put the implant in, you wait 6 months to uncover it, and you wait another 3 months before you take an impression. So normally my patients would get an implant maybe 18 months to 2 years afterwards. But immediate implant placement, it's not about just ticking all the boxes exactly as you've said, but it's ticking all those boxes to try and get a predictable outcome. It's a predictability of the outcome that puts me off immediate implant placements. However, all the research says that if you take upper anterior teeth out, the way to preserve the bone, the way to preserve or give a best chance of getting a good aesthetic score there is by using an immediate implant.
Yeah, but if you think the bone in a bony envelope, you need to have all those walls present. Now, the biggest advantage in immediate implant placement, or what is going to lure me towards it, is I'm not going to raise the flap.
Yeah.
But if you're not going to raise the flap, you need to have proper knowledge of that bony anatomy, bony envelope. For example, if you're not going to raise the flap, if buccal plate is missing and you do not know, then what's going to happen? It's a disaster.
And if you can't see an infection, if you haven't got a 3D image, you haven't seen an infection that's going there, everything will fail. Everything will fail very, very quickly if there's untreated infection. But in terms of the reps, getting them in, getting the different kits, all the reps can come and see you and show you a kit. It would be better if it's not a rep that's scrubbed in and holding your hand while you're putting an implant in for the first time. You'd want someone, a mentor, or you'd want to be doing it around someone who's used that kit before, or with someone who's used that kit before. And ideally have a go on some extract on some of those plastic models so you remember the sequence in which you're going to drill. Because getting your nurses trained up to put these things back in the right place is vital. Because if you think it's the right drill and you pick it up and use it, and then you look at the small print that's laser printed on the very, very tiny bit of it, and then you realize it was a next drill up that you've used and you've over prepared the hole, there's no going back. So it's important that these things are all used in sequence. The precision here of what's being done to the bone and the precision here in terms of asepsis, this is one of the things why my failure rate is very, very low, because I cherry pick the cases. I have no compromise when it comes to asepsis, and I'm very quick and delicate with the tissues that I'm using as well. I don't use PRF. I don't do a lot of soft tissue grafting unless it's absolutely necessary. And Kash, I think you're the same.
Yeah, and if you're going to use the bone graft, then you need to thinking about what kind of bone graft you're going to need. What do you want from it, you see? So there are different kind of bone grafts which are available, which have got different use. So you need to be very clear what kind of graft you're using and what are you actually planning to achieve from it.
Just a quick word on CBCT. This is a scanner that I have in my London practice. My other practices don't have them, and I refer them out to get those done. It is essentially just a 2D sensor but it rotates around your head, so it allows the machine to computerized tomography-wise create a 3D image for you. There are regulations produced by the Health Protection Agency in 2020, and this is the most recent one by Sidentex CT in 2012, but it does cover all the training that's required for you to be a referrer or to take them or to report on them. It's all in this document here. You can go to Sidentex CT website to find out. But now to do implant dentistry without cone beam CT, I think it would pretty much be indefensible if you drilled or the implant touched something that it shouldn't. Okay. For example, here you're looking at a low right 6, where I have got a stent in place, a radiographic stent in place that shows me the long axis of the restoration I've planned. in this area here. It's highlighted on there. So the patient is wearing this. When I've done a small volume CBCT, that's the other thing. You've got to get the radiation as small as you can. And I can see it in 2D, they're all 2D images, but I can measure it in all the dimensions. I can see the buccal plate here, and this is a healing socket. And this type of socket near here, when you raise a flap, there's going to be there's not going to be full bone here. So unless you plan to graft it, you're not going to be able to put a long implant in, so we end up planning a shorter one here. But it has to be prosthetically driven. The most important thing for implant placement right now isn't whether it's short or long, or it's having the soft bone. The implant is in bone, having good keratinized tissue around the top, and just predictable stability of the outcome, the aesthetic and the functional outcome. The whole thing is a team effort. Your nurses aren't just there to clean your instruments and autoclave them. My nurses take x-rays as well. They'll do the treatment coordination stuff with the patient as well, run through the treatment plans with them, make sure they understand what's happening each day. All the dentists, the hygienist, therapists in my team are trained to talk to patients about implants. We have animations on software of excellence. It's called, I think, Guru, and on Kodak Carestream, Kash, is it CIC, Communicator.
Yeah.
Got those graphics, haven't you, to show the patient, and you get these little models as well. But the whole team need to focus on the patient. The whole team need to be focused on the patient and their needs all the time, and to be making sure the patient understands what's going on all the time. It starts with your receptionist. The receptionist is the first point of call for most of your patients. And if she gets a nosebleed when a patient calls up and says, I've got a problem with an implant, then that doesn't help. Okay, she needs to be able to say, that's not a problem. We've got someone who can look after you. Okay. There are things that practice do. I know my brother-in-law does this out in Gloucestershire. He has evening events. So all the team, the nurses, receptionists and the dentists will make a list of names, interested parties, people who might be interested in having an implant because they had a tooth out recently or they're going to have a tooth out. As Kash was saying, it starts from the point at which someone has been told they're going to lose a tooth. And they can have focus group meetings, get them in, do presentations for them, or ask them, other patients, to come in and talk to them about their implant experience of the implant journey at your practice. And you look at reviews and look at feedback. Advertising, I don't need to tell you guys about Facebook and Instagram. You're all Instagram dentists. And then this is an advertorial. This is, again, my brother-in-law out in Gloucestershire. But it's about focusing on what the patient needs. The patients tend not to care how much titanium you can get wedged in between their buccal and palatal plates of their maxilla. They tend to care what they're going to do with the restoration that you stick on top of that, how predictable that's going to be, how long it's going to last. My last thing is about mentoring. This is one of my mentees, Dr. Mabeen Ahmed, who came on a 5-day course that was organized by Kash in Mexico to put 10 implants in, and that was 2 years ago. And since then, I've been going to his practice maybe once a month, and he's placed his 10 implants since then. I've trained 2 of his nurses to drape the surgery and stuff like that. So he was pretty much, for simple single implant cases, he's pretty much on his own now. He can pretty much do it himself. And again, what I told you about when I did my MSc, the important thing about that experiential learning. So I may have only taken 1 patient to the clinic that I used to visit on Harley Street on a Saturday, but I would be there for the whole day because I'll be watching other dentists bring in their patients and assisting them, watching the patients after that. Next stage is having impressions or having uncover, and just being around it every Saturday, just being immersed in implant dentistry, looking at the different cases and the different problems they bring up, and then how to solve those problems, and watching how and analyzing and doing a reflection on that. It was really, really important doing that reflective log of the observed sessions that we did throughout those 2 years to get a diploma. And then the MSc year was just the headache because it's all about research. But the diploma year, in terms of getting your clinical cases done and getting a portfolio of cases done from simple to complex, that is where you will get your experience, your true experience, and your true education and training in implant dentistry. So I've said, me and Kash, we are available for advice, questions from any of you guys now. We're coming up to 9 o'clock now. I've got 5 minutes. please do get in touch with us either directly or by email, or you can chase us up on Facebook and Instagram. We're on both of those as well. All right. So I hope that has given you a kind of idea of what the essential skills are for becoming an implant dentist, or becoming being able to provide implant dentistry in primary care practice. And I will hand it over to my colleagues here, Kish, Jin, and Kash, to ask me the questions or answer your questions.
Absolutely fantastic. Guys, thank you so much for covering so much information in the short time we had, and covering the essentials, catering for those who are starting an implant journey and those guys who are further down the line with implants. So thank you once again, both of you, for the input. And again, I could feel the passion both of you guys have, not just for implant dentistry, but for the mentoring as well. Absolutely fantastic. So thank you, guys. We've got some few questions. I mean, obviously in the current times we are in, and this is for guys who are currently doing implants. When do you think we'll be able to do implants back in practice?
That's like some magic bullet is the question, isn't it? How long's a piece of string? I suspect when we are allowed to do routine dentistry again, which probably won't be for another 6 months from when we open. So when we open, I think we'll be open for emergencies only, non-AGP, or AGPs will have to be referred, and they will be urgent only. The moment we can do routine dentistry again and AGP dentistry again, I think we'll be open for implant dentistry again. Minimum it will be 3 months, maximum 6 for me.
I think we just wait for the guidelines when they're gonna deliver, when we're gonna get it, that when we're gonna start doing the routine dentistry, because Rumit has asked that question. So I think, yeah, second stage surgery again. I think you can't, although there may not be no aerosol, but you need to have that permission for doing the routine dentistry. Ricky Bhopal has asked about when deciding implants you want to use, what are the key features that attracted you, the ones you use? I think the customer care, customer support, the implant should be there in the next 15 years. You don't want to place an implant whose company is going to go bust, and 10 years time or 12 years time, you're going to look for a healing collar and you will call that company. That would have gone worst. So I think that's
they all pretty much, if you look across a used car garage now, pretty much all the cars, 4-door saloons, look exactly the same. Pretty much all implants look exactly the same. You could possibly get a paperclip to integrate in the right circumstances if you really wanted to. So they all do what they say in the tin. It's not, the osseointegration is not the key anymore. Like I said, that's not the magic that happens. They can all integrate. In terms of choosing a system, like Kash says, it's about the way that the people interact with you, the company itself, how much support they're able to give you, and in terms of getting bit components easily, the awkward components to get around complications, if they can help you doing that. Companies that are too big, there's many companies that are too big to do that. There are a lot of reps come and go. When there's a high turnover of reps, that's a warning sign as well. Okay, so, but yeah, when it comes to choosing a company, a lot of it is on location and convenience of the company as well. But they've all got good rep. The top 3-4 companies all got the same success rates. Implants have a very high success rate. If you cherry pick your cases and you you skill yourself up before you're doing it, and you've got a mentor there, you're very unlikely to get things wrong.
Awesome. Thanks, Sumair. Thanks, Kash, for a very, very inspiring and insightful lecture into the essentials of implant dentistry. We have a lot of younger dentists, a lot of guys who have just finished their FD year. So someone like Farhad is asking, when do you think the best time to start implant dentistry is post-FD training?
Farhad already talked to him. He talked one in for me the other day. He started. What's he talking about? They could look, implant dentistry. It's not rocket science, and it's not outside of UK. It's taught at undergraduate level. So in the US, where they are trained to be dentists, they're not trained to be NHS dentists or FDs. They're not prepared for that. They're prepared to be dentists in the big bad world. Yep. So in the US, undergraduate training involves placing and restoring implants. And even some of you as undergraduates would have placed or restored an implant as well. So it's not about when. It's there and you can do it at any time. It's about creating the environment in which you can start learning how to do it and getting into the right kind of, like I said, immersing yourself in that environment. So Farhat, for example, has got me every Friday. I'm at the practice in Essex. There's a couple of other guys that come out and watch me there as well. Some of them bring cases to me as well. It's one of the observation sessions that we do. Ricky's mate, Sandy, who's doing prosto training at King's. He's been up to see me as well. So I'm more than happy for people to come in and see us and watch us placing implants and get them, demystify it for them. Okay, but there's no certain, definitely you should be able to do oral surgery. So you should be able to raise a flap and close it without getting a nosebleed by yourself and within, like, not with the patient in the chair for 8 hours. Okay, you should be able to do oral surgery quick and slick, and then there's nothing holding you back. You can put a post hole, preparing up a lateral incisor for a post hole. You can definitely prepare a hole in the bone for an implant.
Perfect. And I guess part of that is also restoring. When you're ready is probably when you also understand how to restore and how to assess the space and the occlusion side of it.
Without a doubt, you should not be putting implants in unless you know where the restoration is going to go or how it's going to go. As Kash said earlier, it's all got to be prosthetically driven. I got into implants when as an oral surgeon. So I would always chase the bone. Where's the bone? Where's the bone? Follow the bone, put the implants in. You'd have implants sticking out all over the place. And when it comes to restoring them, it's like the Bride of Frankenstein up there. It's just like horrific. Sometimes you have to just remove implants because they weren't in the right place. So if they're prosthetically driven, they will always be in the right place. And then you will always be able to restore them exactly how you've planned from the start.
Fantastic. Guys, we've got another question here. I'll ask both of you. It is from Vinesh. He's asking, how good are short Bicon implants?
I think there's quite a lot of evidence behind short implants as well. So they are good, but you're not going to place a short implant when you've got 10 millimeter of bone. So it all depends whether, if you have got bone and you are too scared of hitting the ID nerve, and you get away with placing a short implant while you would have placed a longer one. So I think assessment, and there's no harm in placing short implants. There's quite a lot of evidence and they work well as well.
Yeah, it's in fact, there's much more evidence about use of short implants being more predictable than there is about trying to grow bone height-wise. That's much less predictable. So the only place to use short implants is in the posterior maxilla, where you want to avoid going into the sinus, or the posterior mandible when you want to avoid going too close to the ID nerve. You need to have at least 3 millimeters safe distance from the ID nerve. So short implants are there, but it's not just Bicon. And Bicon, the issue that I have with Bicon is like some of the earlier caveman type implant, everything's hammered in. Everything is hammered in. There's no delicate screwing or anything. Restorations are hammered in, and then to take them out, everything's wedged out and wedged in, like using a Morse type connection. So that makes me nervous. Hammering implants into bone makes me nervous, but it's because I wasn't trained that way. There are dentists like 10 years older than me who do implants, trained by Tatum, who's a big Texan guy and used to over-engineer everything like the Americans do. If there wasn't enough bone in the sinus, he would fill virtually 3/4 of the sinus with bone so that he could put 15 millimeter implants in. So that's the way that initially it was done, by over-engineering, because it was predictable. But now the evidence shows we don't have to over-engineer. We don't have to use tons and tons of augmented bone. We can put shorter implants in. Bicon, yes, it is a predictable system because it's one of it's very widely used in the UK and in Europe, and it works. So yes, they're predictable, and like most implants are. But anything less than 10 millimeters long is considered a short implant.
Fantastic. Got another question here. I mean, we've got a few therapists and hygienists on tonight's webinar. And we've got your therapist, hygienist, Suraj, on here tonight as well. Where do you see the role of hygienists in the role of implant dentistry?
So the most important thing, once I've restored these cases, is number one, getting the perio stable before you put the implants in and maintaining it stable. And then number two, monitoring the perio of implant patients, monitoring the pocketing around implants, and looking out for early signs. Because peri-implantitis, if you wait too long and you lose a bone, forget about it. You're going to end up losing the implant. It's going to be expensive to try and rectify that situation. So it's treating the patients before. So anytime someone says they want an implant, the hygienist, therapist is their best friend for 6 months before they come near you for the implant, especially if they've got perio. And then once they've had the implant, the hygienist and therapist every 3 to 4 months routinely in there doing the cleaning, making sure they're able to clean under the implant restoration and they're not getting any signs of peri-implantitis. That monitoring is vital. And then the treatment of periodontitis as well. Peri-implantitis, sorry, as well. I've done it with Suraj before and with Waleed before him, where I used to raise a flap. If someone who had peri-implantitis, we could raise, I would take the restoration off. It's usually full arches. Usually I've been there for more than 10 years. We take the full arch restoration off, put healing abutments on, sometimes raise a flap, send it down to the hygienist therapist. They would do as deeper cleaning as they can, and then I would send them back up to me and I would sew them up and put the restoration back on.
Excellent. Perfect. We've got a lot of restoratively trained dentists listening in tonight. And I know you guys both mentioned that taking out like third wisdom teeth and doing surgical extractions is like a must. But that's not something that happens generally. What would you suggest in terms of if they're thinking of doing an implant course and upgrading their skills?
I don't think it's a must. What I said was that's the level of oral surgical skill and competence that is required for you to be able to raise a flap, prepare an osteotomy and put an implant in safely and close it up. The level of skill and manual dexterity that is required is similar to that of a third molar surgical extraction. Kash?
Yeah, I think you need to have those basic surgical skills in order to place the implant. You need to know the difference between your periosteum and mucosa. You need to know how to raise a flap. You need to know how to suture a flap. You need to know how to achieve hemostasis. All these things you need to have grasp on. Otherwise, I think before embarking on an implant course, you need to go on an oral surgery course to clear those, to actually get those skills and then get onto the implant one.
The skills and the tactile feedback.
Perfect. Awesome.
Brilliant. Now, Kash, you were one of Sumair's early mentees. How do you see the role of mentoring in implant dentistry?
Did I not warn you that if Sumair starts talking, it's difficult to stop him? So yeah, I think it's very important that you actually get the right mentor in the start of your career. They need to know you and they need to actually know how you're going to learn. That's very important. Which kind of learner you are. That is the key. And they need to assess you as well before that. So I think you need to have 1 or 2 meetings with the mentor before you actually take him as a mentor. That is very, very important. And I think it has been brilliant. We still actually do implant cases together, believe it or not. And if it's been about 15 years, but still we still have our own opinion in front of the patients. And you know what? Patients love it. They think that you actually are giving them so much importance that you guys are actually having an argument for them to have the best possible care. So I think our patients love it. When we have, we're not agreeing on a point.
It's a two-way thing with mentors and mentees. Yeah, mentors, it's incredibly rewarding for mentees to see them develop and they're learning and they're just as they're absorbing things and being able to do things that they weren't the last time you saw them, and then just a confidence. But also you learn from them as well. You learn about yourself as a teacher. You learn yourself. You have to stay on your toes, or you ask them to go and research something. You have to then go and learn from them. So it's a two-way thing. I've enjoyed every single minute of being mentors for everyone I've been mentor for. Jin, Kish, Ali, and Kash. It's brilliant, and I enjoy taking on new mentees as well.
Fantastic. Just going on from that question there, obviously you guys are based in London. How can guys further up north or in Wales and stuff find a mentor? I know there are a lot of associations, implant associations? How can they find a mentor?
They can. I think I don't know whether most of your attendees would know. Me and Sumair are one of the very few persons who have done a postgraduate certificate in mentoring and coaching. So we have got the postgraduate qualification and that, but we actually go to different places to mentor as well.
Kash goes further than I do. Kash travels. Kash is happy to travel. He's happiest when he's traveling, but he'll go to Scotland.
So yeah, just you've got our details. Contact us, and that can be arranged.
The thing is, we know because of the amount of time we've been doing implants. We know people in pretty much all over the globe, let alone just all over UK. So we can put you in touch with people that we think would be happy to mentor you as well. So it's up north as well. There's plenty of really, really good implant dentists, really experienced implant dentists who are also very good at teaching and very good mentors. So we can put you in touch with people as well. That's not a problem.
Brilliant.
There's companies, a lot of companies have their own mentor network set up anyway. NEOS, Nobel Biker, they've all got their own, a lot of companies have a network of mentors as well.
So those of you guys who want to get into implants, what I recommend is the ADI, the British Association of Implant Dentistry, which these guys are part of. Contact them, reach out to them, go to their, obviously, when it is social distancing reduces, go on their days and do the networking. There you can meet some great mentors through the network as well. Fantastic. Kash, have we got another question?
Yeah, so we've got one question from Ramit. He's asking with regards to scanning and implants, in your experience, which is the slickest system you guys have used in terms of pre-surgery planning and scanning the implants with the scan bodies and then getting the restorations made as well?
I'm a dinosaur, so I don't do it. This is something I've had some experience of using the Carestream and using the Prama system, but I much prefer to take impressions the old-fashioned way. But scanning, in terms of scan body impressions, I know that it's good for singles. It's predictable. My buddy Victor does it a lot for singles, and he uses Osteocare. So they've got it, and Megagen have it as well. But when it comes to multiple units, especially full arches, digital scanning impressions, the research has showed, and this is the conference that we were at in Ukraine a few months back, Kash, where they showed that the research shows that for full arch cases, the digital scanning is not as accurate as analog.
Perfect. Thank you. I think that's all of our questions done for the evening.
I need to give a shout out to my FDs in Oxford, otherwise I'll get crucified, especially Hannah Mauer. Okay, so big shout out to the FDs in Oxford who have all tuned in, and thank you for everyone. I know we've taken up a lot of your evening. It's a nice sunny bank holiday Monday. I understand it's a stressful time as well, being away from work, not being able to go into work, and we don't know what the future holds. What I will say is just keep positive. Remember that you are upskilling. The whole thing about webinars and courses is you are upskilling. Keep upskilling, okay? Because at some point you will be prepared to take on the opportunities, so you're building your own luck.
Perfect.
Thanks a lot, guys. Thank you very much. Thank you very much. You did a great job.
Brilliant. So
Okay.
look, for us guys, thank you so much. Go for it, Sumair.
Yeah, just saying thank you everyone for your time. God bless. Get in touch if you want to know anything else.
So look, from us, Smile team, big thank you to Sumair and Kash for their time and experience and knowledge on implant dentistry. I know these guys are fantastic clinicians and fantastic mentors. So anyone who wants to start their journey, I know both of them will welcome you with open arms and give you advice on which way to go pathwise. Do reach out to them. I know they are planning a diploma course or something in the background, so do keep in touch with the Smile team and we will keep you up to date with that as well. But thank you to each and everyone who logging in tonight. Next week, we're going to do something for the foundation dentists, so something to do foundation training, which we'll go through as well. But for myself, enjoy the weather, enjoy this week. We have no clue when we're going back to work. I know a lot of clinicians are going back next week. We're still waiting for guidance, but keep positive, as Sumair said. and keep enjoying everything you're doing. Kish.
Yeah, just to echo what Jin said, I think we don't know when we're going back. We don't know what's happening. There's a lot of uncertainty. But I always say focus on what you can control and don't focus on what you can't control. So just stay positive, keep strong, and the most important thing, stay safe. If anyone is going back to work, make sure you're doing everything in the correct way with the enhanced PPE. Don't rush into it. Just be safe.
That's it. And if you guys are doing these, a lot of you guys on this, I mean, if you're enjoying it, reach out to us. If you've got any questions on any tips, anything, you know, we can put you in touch with all our lecturers, from Marcus to Ricardo to Janos and these guys as well. So do keep in touch. But otherwise, we will see you next week on Monday Night Live. Thank you very much, guys. Shout out to Sunil, Lord Biliriki, as well, who's here today with us. And guys, we'll see you next week. Have a great week. God bless everyone.
Take it easy, guys.
Thanks, guys.